Hello, everyone. This is Rosie Talaga with Becker's Healthcare. Thank you for joining us for today's webinar, Team Readiness, How to Prepare for New CMS Mandates. Before we begin, I'll walk us through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a Q&A session. You can submit any questions you have throughout the webinar by typing them into the Q&A box that you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording later. If at any time you have issues with video or audio, just please try refreshing your browser. You can also submit any technical questions into the Q&A box. We're always here to help. With that, I am pleased to turn the floor over to Sarah Jenkins, Principal of Healthcare Strategy at GetWell, to get us started.
Great, thank you for the introduction. I'm excited to be here with everybody today. Just a little bit of background on me. As a Principal of Healthcare Strategy here at GetWell, my role is to partner very closely with hospital and health system leaders as well as payer leaders to ensure that GetWell is aligning with their organizational strategic priorities. Prior to joining GetWell, spent a number of years in clinically integrated network design and development for a value-based care enablement company. And then prior to that was at the advisory board in a healthcare strategy role in their best practice research division. Before I dive into our agenda today, I want to hand the mic over to my fellow presenters to introduce themselves. Jonna, do you want to kick us off?
Sure, happy to. Thank you, Sarah. Thanks so much for having me. My name's Jonna Juby, and I'm the AVP for Population Health and Clinical Operations. I've been with the organization for about 25 years now. I'm an ED nurse by training and have had several roles at UMass Memorial Health. Thanks again for having me today.
And Rob. Oh, I think we're not hearing Rob.
Okay. Well, hello again. I'm Rob Mechanic, Executive Director for the Institute for Accountable Care. We're a small health policy research firm that works with Medicare claims data and focuses on accountable care and with a long history in working in bundle payments.
Great, thank you. Well, I'm excited for the discussion that we have planned for today. Over the course of the next hour or so, Jonna, Rob, and I will share a background on the Transforming Episode Accountability Model, also known as TEAM. So we'll cover what the model is and how it works, what participants should be aware of in terms of opportunities and risks, and some operational recommendations for succeeding in TEAM. As Rosie mentioned, we have built time in for Q&A, so please feel free to use the chat to submit questions, and we'll do our best to get to as many as we can at the end of the session. So for those of you who are maybe unfamiliar or need a quick refresher, TEAM is a new mandatory bundle payment model from CMMI, launching January 1st of 2026. While this model is mandatory for hospitals in selected CBSAs, there is a voluntary participation track available for hospitals who have previously participated in CJR or BCPI Advanced. And UMass is actually one of a handful of organizations who has voluntarily aligned with the TEAM model. So John, I'm really looking forward to your perspective on this later in our discussion. The TEAM model includes 5 surgical episodes: CABG, major bowel, lower extremity joint replacement, surgical hip and femur fracture treatment, and spinal fusion. For these 5 episodes, participating hospitals are responsible for the cost of the procedure as well as cost of care 30 days post-discharge. Hospitals will continue to receive Medicare fee-for-service payments, but total episode spending will be reconciled against a regional benchmark price that CMS sets. How hospitals perform against that regional benchmark will determine whether they earn a positive or negative reconciliation, so essentially a bonus or a penalty. The positive and negative reconciliations are further adjusted based on performance against a composite quality score, which includes 30-day all-cause readmission rate, the CMS Patient Safety and Adverse Event Composite Measure, PSI 90, and then patient reported outcomes for lower extremity joint replacement. Given these factors, successful participation in TEAM will be dependent on active patient engagement pre and post-procedure, as well as tight coordination across the care continuum to optimize quality and avoidable cost. Now, some of you may be wondering, what is GetWell and why are we here talking about TEAM today? GetWell, now part of SAI Group, has been in the business of digital patient engagement for 25 years. And we partner closely with hospitals and health systems like UMass Memorial to drive scalable patient engagement in both procedural and chronic care episodes. Our high-touch digital engagement platform helps to guide patients before their procedure by delivering timely education and reminders, helping them to understand what to expect from their care, and also helping them to complete any necessary pre-surgical preparation. This proactive patient engagement improves clinical outcomes, reduces administrative burden for care teams, and lowers that risk of last-minute surgical cancellations. Post-procedure, our platform continues to do that patient engagement with personalized education and symptom monitoring, as well as automated escalations to the care team as concerning symptoms might arise. Those clinical escalations are surfaced through the native workflow in the EMR for that clinical care team. We also facilitate collection of patient-reported outcomes, helping to ensure that kind of continuous feedback loop, supporting quality improvement and value-based care success. In collaboration with our partners, GetWell has driven measurable reductions in episode cost of care, primarily through reducing that 30-day all-cause readmission rate, while also helping to support driving high levels of patient satisfaction. At the same time, we significantly ease that administrative burden on physician practices by reducing the amount of time and resources needed to support patient education, and also reducing the number of inbound calls and questions that practices are fielding from patients, whether that be pre or post-procedure. And Jana will be sharing a little bit later in the discussion how UMass has partnered with GetWell kind of over the years to support success in episode payment models, as she offers some best practices from their experience in BCPI Advanced, and how they're thinking about carrying those best practices forward into TEAM. But before I turn it over to Jana, I do want to have Rob kind of take the mic and talk us through a bit more detail around TEAM, and also share some of the insights from the financial modeling that the Institute for Accountable Care has done. So Rob, I will, with that, hand it over to you.
Okay, absolutely. Thanks, Sarah. So I'm going to talk a little bit more about the TEAM model, just a little bit about us, the Institute for Accountable Care. We are an independent nonprofit research group formed to do health policy analysis and focusing specifically on accountable care strategies. Our team has actually worked in bundle payment since prior to the original bundle payment for care improvement. Our team has built episode groupers as well as supported hospitals and health systems. We have built because we have access to 100% of the Medicare claims data, it allows us to replicate these Medicare payment models. TEAM is actually relatively easy for us to replicate, and we can provide detailed financial reports showing the opportunities for improvement relative to peers for people in the model. And actually, we did work with Jana and her team at UMass Memorial as they were making their decision about whether to voluntarily opt in to the TEAM model. So what I'm going to cover today, I'll talk a little bit about how TEAM is different. I'm going to spend a fair amount of time on describing how the payment model works, and because that's important for all of you who are getting into it and for your stakeholders. I'll talk a little bit about who is in the model, what we learned, and analyzing across the model of financial impacts, both pro and con on hospitals. And then I'll talk a little bit about performance improvement opportunities. So, going back to TEAM, why is it different? Obviously, it's mandatory. There was one prior mandatory model, CJR, the Joint Replacement Program. TEAM is about 5 times as big. Around $6 billion of revenue is going to flow through TEAM in the first year. Second of all, it's focused on surgery. And that's important for a couple of reasons. One is we think CMS did this because surgical episodes have less variation, but of course it doesn't mean they have no variation. And one of the issues with surgical cases, they tend to be much lower in readmission and lower in use of post-acute care than chronic medical episodes. And so on the one hand, it reduces the variation. On the other hand, it also reduces the opportunity. And so that's an important piece. Third, it's a 30-day model, not a 90-day model. I think for hospitals, this is much preferable because they don't necessarily feel like they can control what happens to the patient beyond 30 days. It gets much harder at the 60 and 90-day point. So it's a nice in-between. And it also reduces the variability in costs. Finally, the pricing model is a regional pricing model. So if you think about bundle payment for care improvement, I'll call that an improvement model where hospitals compete against themselves and their historical performance to improve. One of the issues with BPCI is it gets rebased every year. So there's essentially a ratchet. You improve this year, your target prices get ratcheted down, and you have to continue improving. On the other hand, team, you're competing against the region. And so you don't have to keep beating yourself. You just have to move faster than the region, which includes both team hospitals and non-team hospitals. So there really isn't a ratchet. But because it's a regional pricing, depending on how efficient you are today relative to your region, you could be starting either with a tailwind or a headwind. So this looks pretty complicated. I'm going to go through it fairly quickly. But the general approach of the model is we start with the national all inpatient prospective payment system hospitals, and they look at the bundles, and because the prices differ, Medicare payment rates are different across the country, they standardize all the claims to be on a common baseline, and then within the region they calculate the standardized regional average spending per episode. And they break this down because most of the episodes are multiple DRGs. They actually calculate regional prices on a DRG by DRG basis within the episodes. Now, there are also some outpatient bundles that are part of this. In the outpatient bundles, those are actually pooled together with the inpatient DRGs, and I can talk a little bit more about where that happens. So they take the regional average. There's then a risk adjustment that has a whole range of factors I won't go through in detail. Once the risk adjustment is done, and so it's really to adjust the regional prices to match the risk characteristics of the hospital's patients. Once that's done, they apply a discount, depending on the episode, 1.5% to 2%, and then a series of target prices. And again, there's a target price for each DRG within the episode, which is probably a little bit more precise way to do it. Now, here's a numerical example, just walking through, again, for a real hospital, how that target price gets built. So you can see this is in the lower joint replacement bundle. There are 4 DRGs. And so each DRG, you can see the number of cases. Then we include a variable we call the DRG index. And basically it says relative to the lowest cost 30-day DRG bundle, what's the mean cost in the region of that DRG. So for bundles with DRG 469, they're about 72% more expensive on average than bundles with DRG 470. So we walk through, so we start with the regional base price. This is, again, a real example. There's something called the PCMA, or patient case mix adjustment, or the risk score. It adjusts from the regional case mix to the hospital's case mix. We take the discount and we get an episode target price, as you can see here. And then for this example, we're showing the hospital's actual spending and a gain or loss per episode. And then the total impact would simply be take that gain or loss per episode and multiply by the number of cases in each one. Now, as I said before, because they're surgery, the profile is a little different than the bundles in BPCI. So if you had somebody in, for example, acute medical, something like heart failure, 2/3 of the cost are going to be in the post-hospital discharge period. Much higher rates of readmission, much higher rates of post-acute care use. Here, the blue is the the facility fee paid to the hospital during the surgery. The red is the Part B and professional services during the surgery, and then the light blue is the post-acute care spending, again, including readmissions. And so you can see for many of these, the opportunity in that piece of the equation is less than it has been in previous bundle models. Just a little bit about the characteristics of team, and here the CMS made a special effort to go into regions where both there had not been a lot of bundle payment participation, but also they wanted to include safety net providers. And so I really think about these in 4 groups: urban non-safety net, urban safety net, rural, non-rural safety net. You can see that the bulk of the hospitals are in the urban non-safety net, but there's a fair number of safety net hospitals. Now, one of the reasons that's important is because there are risk corridors in this program. And so the safety net hospitals, if you qualify, you are not subject to any downside risk until 2029. All of the non-safety net hospitals are subject to downside risk starting in 2027. So they get 1 year of no downside risk for everybody, and then everybody else moves to downside except for the safety nets, which have a little bit more of a breathing period. And again, to qualify, you have to exceed the 70th percentile for your proportion of patients who are dually eligible or are eligible to receive the Part D low-income subsidy. So this is actually interesting because it is influenced by how generous the states that you're located in are. And so, for example, in California and New York, which have very generous Medicaid eligibility, a lot higher proportion of the hospitals actually qualify for safety net and then get this protection for the first 3 years of the program. The other thing I'll say about participation is there's a lot of small hospitals in TEAM, as it turns out. So the top 20% of hospitals, so with 500 or more cases, account for about 55% of the total dollars of the $6 billion that have flown through this model. At the same time, if you look at the bottom half, which is those hospitals with less than 200 cases, half of the hospitals account for 15% of the dollars. So it's sort of very interesting how there's so many small providers in this model. Because of the regional pricing, so these regions are not small regions, they're big regions. The regions are called census divisions. There are 9 census divisions in the United States. And so, for example, the census division in New York would be New York State, New Jersey, and Pennsylvania. Census divisions have up to 8 states in them. And so it's a wide variety, and within these large areas, of course, there's a lot of variation in how efficiently hospitals produce the episodes. And so what happens is you can see in the green areas here are where there tends to be, if hospitals were to be in TEAM today, they would be in positive territory right off the bat before they doing any care redesign. Where you see orange and red, they would be losing money. And so if you compare, for example, New York City, mostly red, and in this Northeast Census Division, Western New York, mostly green, because their costs are much lower than the city. Same thing you'd see in California compared with Seattle and Portland area. And so geography in some sense is your destiny, and there are certain geographies where most of the providers are going to be behind the 8 ball and others where they will initially benefit from being in the program. So just to give a sense of the distribution, this is looking at all the hospitals with at least 200 cases and mapping out their gains and loss per episode. You can see about 65% of the hospitals would tend to be would tend to lose money if the program were in effect today, and about 35% would make money if the program were in effect today. But of course, a number of these are safety net providers. So if we go and say, what would this look like if the safety net providers opted to stay in that no risk track, you'd have this big group in the middle that had no upside and no downside, although some of the safety net hospitals would be on the positive side of things. So just to give you a sense of some of the data that we provide when we work with hospitals, this is sort of a summary of what it would look like with a sample hospital. We're looking at each episode category, the number of cases. We've built the target price, and so we compare that to their actual spending. And so you can see, for example, this hospital does about even, except when we get in the orthopedic space, in which case there's losing a lot of money in joint replacements and in surgical hip fracture repair. I mentioned before that some of the episodes include both inpatient and outpatient. So this is, again, looking at this same hospital. About 40% of their cases are inpatient, 60% of their cases are outpatient. You can see almost by definition, because it's a blended rate, the outpatient cases are money makers and the inpatient cases are money losers. Now, one of the issues here is that on the inpatient cases, you also have in this episode category people who have hip replacements with also a hip fracture, and those are included in there. They tend to have very high post-acute care costs, and so you can see these big differences between the inpatient and the outpatient, and that is mostly driven by post-acute care spending. Just to give you a sense, so for the same hospital, we're looking at all of their joint replacement cases, and you can see the hospital is the red. We're benchmarking them against their local market and against the census division. And the thing that jumps out of this chart is that they're really spending a lot more money, about $1,500 a case on inpatient rehab facilities. And that's even if after you adjust for the case mix differences. So this is one, now we don't know if this particular hospital has its own rehab hospital, and that may be the reason for the high rate of referrals, but in any sense, it disadvantages them in this model, and it's something that they're going to have to take a closer look at. So in getting ready for the team, what we recommend, number one, you have to understand the model and all the subtleties in the model really well. The second thing that you need to do is sort of understand the financial impacts, whether you're ahead or behind, but more specifically, where are there opportunities in your care processes to improve? And so these financial reports that we provide will really highlight quickly areas where you should dig in and look further. The third piece, once you know the model well, you really have to educate your clinicians and your care teams who are going to have to be operating. And this is really a great opportunity to engage your surgeons and the surgical teams, as well as other folks on the care team, in trying to build new workflows that incorporate the best practices. And then finally, because the post-acute, although it's not as big as in prior bundle models, it can be significant. And so it's really important for hospitals to identify and engage with downstream providers, particularly skilled nursing facilities, who will work with them and try to help them keep their costs to a minimum, which is not the typical MO for a nursing home. Finally, though, as I said, the inpatient process improvement is really important, and it's really interesting. When we started in BPCI, we were working with a lot of academic medical centers, and they were totally focused on how do we re-engineer our inpatient care. And we said, hey, look, if you looked at your financial reports, you're spending a ton of money on post-acute care, and you need to focus there. Today, that's been really how BPCI is involved, and all the consultants today are running around saying, post-acute care, that's where you have to get your savings. But I think it's really important for both the patients and for potentially improving your performance here is to really focus on the inpatient side. I think of this in terms of developing programs for the pre-surgical, intraoperative, and then the post-op periods. And I'm not going to go through all of this detail, but I think your most successful efforts are going to both work on the inpatient care redesign, that care transition period, and then the post-acute care management. So with that, I'm going to wrap up and hand over to Jana.
Thanks so much, Rob. Appreciate it. So I want to give a little bit of background about UMass. UMass Memorial Health is the clinical partner of the University of Massachusetts Chan Medical School, and it's the largest healthcare system in central Massachusetts. It's a non-for-profit healthcare network providing all levels of care, from primary care to tertiary care. We're involved in several value-based programs. We have a Medicare ACO with over 40,000 members, a Medicaid ACO with over 40,000 members. We're also involved with the BPCIA as well as Primary Care First. What's interesting and of note of the value-based programs is about 62% of our bundle patients are actually in our Medicare ACO. So as we have initiatives and improve savings and outcomes, we share savings in both of the programs. As you can see, we're a very large network. We have a total of 1,322 beds. We employ over 2,500 physicians, 4,700 nurses. We have 20,000 employees that all really have the same mission of being the best place to get care and the best place to give care. We see over 1.6 million ambulatory visits per year, and we have 60,000 inpatient discharges. Here you can see we have 5 owned hospitals, which are Health Alliance, Clinton, Harrington, Marlborough, Medical Center, which is University and Memorial, Hahnemann, and also Milford Regional. Of note, also, we have 70 community-based practices that really span across the region. We have several joint ventures, but a large organization. I wanted to talk a little bit about the key strategies for success as you're implementing this model. And I think the biggest one is really getting your senior leadership to understand what the model looks like and organizational goals that align to the bundle payment goals. Meeting with your COOs, your CEOs, and the presidents just to make sure everybody understands what the bundle program is and how it can really benefit the hospital as a whole. Next is monthly operation meetings with current data and key stakeholders. So really identifying your teams in that particular episode. If it happens to be CABG, making sure you have your surgeons on board, your case managers, your PT, OT, and most importantly, your navigators, which really play a big role in the BPCIA program. Also leveraging your electronic medical record just to make sure everybody in the system knows who's in the bundle program, who's on part of that care team, and how can you get a hold of that navigator with any questions that you might have. I can't stress enough the impact of the nurse navigator's role in driving integration of care. When we think about the bundle program, we discharge patients with sometimes a 30-page after visit summary, and then we send them home, not in their best health, and think that they might understand that 30 pages. Having the nurse navigator call them the day after discharge, going through their medication reconciliation, making sure they understand their medications, making sure they have a follow-up appointment are all really critical to the success of the program. Communication strategies and implementation is really important. We do a newsletter just to make sure everybody knows what the bundle program is. It's a small population in a big organization, and making sure everybody knows what the bundle or the now teams program is really important. Interpreting the quality data and transparency, to Rob's point, is really important. Understanding your data so that you can come up with mitigation strategies, and really transparency to the physicians. Like Rob mentioned, the index stay is really around standardizing how all the surgeons work. They all work very differently, and really standardizing what they do pre-surgical, during surgery, and post-surgical is really important to have standard clinical pathways that have proven evidence-based outcomes. And then creating partnerships with your post-acute facilities, like Rob mentioned, is critically important, especially for our hip fracture patients. They do typically go to post-acute, and really building preferred networks with those post-acute partners is critically important. And the last thing I would say is just leveraging new technologies. I've been an ED nurse for a long time, and we didn't have a lot of the new modalities that we have today. Mobile integrated health, which is our paramedic ran system, where paramedics can go to patient's house and give them a liter of fluid or check their sugar, is really critically important. Sometimes that's all that patient needs to avoid an ED visit. We're also working really closely now with digital medicine. Is there digital technology for our COPD patients with Spire? We're partnering with digital partners to make sure that we're capturing all of the modalities that are important in taking care of these patients. I want to talk a little bit about our partnership with Get Well. We actually partnered before I came into this role back in 2015, and it's important to note that the bundle program actually funded the Get Well program, or paid for the Get Well program in the beginning. And they thought it was that important that they wanted to invest in that program because of the value it brings, both pre-surgical, intra-op, and then post. So we began our partnership back in 2015 in orthopedics with the total knees and lower extremity. In 2021, we really integrated Get Well with our ADT system so that it was a bi-directional integrated system so that it could automatically know our surgical patients and be able to onboard them onto Get Well. We started cardiology in 2021. And then in 2022, we launched the stroke care plan to improve patient engagement. And stroke was a new one for us. It's a medical, which is a little bit more challenging. For surgical procedures, oftentimes we have the opportunity to educate them about Get Well and about the loop. In stroke, as you know, they come in urgently and we don't have that opportunity. But we are finding a great value in making sure we have a Get Well loop guide for stroke patients. We then expanded in 2023, which is really our biggest expansion, into endoscopy, colonoscopies. It's probably our largest volume of loop, and we all know how complicated instructions are when you have a planned colonoscopy the next day. So we started that in 2023, as well as bariatrics and spine. Then lastly, in 25, we expanded to urology, and we're also working closely on a new loop for patients with behavioral health in our primary care settings. And I think this will play well with the TEAMS model. Some patients may not have depression or anxiety on their problem list, but the thought of having surgery can really cause some anxiety around that surgery. So having a loop that goes to patients that talks about how to handle anxiety pre-surgery is, I think, going to be a great addition into the new TEAMS model. Benefits of working with Get Well have been many, but really having the patients automatically enrolled through the integration with scheduling has been a game changer, I would say. They have excellent professional education, which improves patient outcomes and reduces complications and cancellations, I would say. A lot of my clinics have paper instructions that may be from 10 years ago or 15. They may be different. They might be Xeroxed 3 times. And so this really lends to giving patients the most up-to-date current information and videos so that patients can look at, what is my knee surgery going to look like? How can I make sure that I'm really prepared? Digital enhancement has reduced practice call. I would say this is the biggest benefit, one of the biggest benefits to Get Well. In a lot of our clinics, we have a call abandonment rate problem, as I'm sure many of you do, and really being able to decrease those amount of phone calls that are coming into clinic, but more importantly, having one call resolution. A lot of time a patient will call and they'll talk to your ASR that then sends a message to the APP and then sends a message to the doctor. And really with this program, we really try to make it a one-call resolution. APPs can monitor and answer these questions in real time and really deletes and mitigates a lot of waste in our clinics. Patients' ability to send photos to support appropriate clinical escalations. Sometimes a wound that looks really scary to a patient is really just a normal wound that they just want somebody to look at and say, it's okay, you don't need to worry. And that really can save ED visits, urgent care visits, which all are additional costs within this 30-day episode. We've had high patient satisfaction scores, and they're automatically pushed to rating sites such as Health Grades and Vitals, which is really important, and it just gives us more marketing around our surgeons, and we score very highly in that category. Epic integration supports native workflows and system tech strategies. So we embedded this into the normal workflow for those first responders so that they don't have to go into one program, then into another. So really trying to streamline and make sure that they can work in one program at a time. The last thing I'll say about the Get Well loops is what's really important is we create a loop based on what we know. But as patients' questions come in, we can really learn from those questions. If everybody is always asking about anticoagulation, or is everybody always asking about TED stockings, we can incorporate that into the loop and really decrease the number of phone calls that are coming into our clinic. More importantly, giving the patients the answers that they need. So really identifying themes, and then we can add them into the loop very easily. So in the past 2 years, we've had a 73% activation rate, which I think is really impressive. So 73% of our patients activated in the loop getting this information. 91% of our patients were satisfied with their post-discharge guided care. 94% of our patients are extremely likely to recommend their provider. This is really good information to share with your surgeons. I feel like we don't do this enough. We don't recognize our team for the great work they do, and they provide comments. And I really try to share these comments with surgeons because they do great work, and I don't think we recognize them as much. So really being able to share this, not only with them, but with the care teams as well, because as you know, it's a team sport in all of these episodes. And then 83% of our patients indicated that they were reminded of a followed care instruction that they may have otherwise forgotten because of this guided care plan. Remember, a lot of our patients, right, Medicare patients may be older, they're overwhelmed coming in for that day of surgery or that inpatient stay. And literature shows that they, I think, remember about 13% of what they were told in the hospital. So really having these resources to reinforce not only for themselves, but for the family that a lot of times helps take care of them is really important. And then practice efficiency. 89% of patients indicated that they were able to avoid unnecessary phone calls or visits because of using their guided care plan. Really important in the TEAMS model. Anytime we can avoid an unnecessary ED visit is critically important. And when patients call the clinic and they can't get a hold of somebody, usually their next step is to go to urgent care or go to the emergency department. So leveraging Get Well has been such an important factor. I think that might be my last slide. Excellent. I'm going to turn it back over to you, Sarah.
Great. Yeah, I think we have some time for Q&A. I think, Rosie, you were taking a look at the chat and the questions folks were submitting for us. So if you don't mind kicking us off with some Q&A, that would be great.
Yeah, absolutely. Thank you, Sarah, Rob, and Jana, for such a wonderful discussion. Now we will be getting into some Q&A, so everyone in the audience, feel free to submit your questions. We've got some great ones throughout the presentations, but continue to type in any questions you have along the way in the Q&A box on your screen. And we will get started with the first question, which is specifically looking to talk to Jana for organizations new to value-based payment models. What do you do today, and what do you do in 6 months?
That's a great question. So I would say today, the first and most important thing to do is really engage your leadership and identify your key stakeholders. Understand what their current workflow is today so that we can really understand how we can look at the model and see where improvements might be made. Meet with your Epic team. We really can leverage Epic and do that sooner rather than later. Sometimes that takes a little bit longer for builds. It's not a big build. We've been able to really come up with great structures, but I would meet with your Epic team just to create workflows so that we can identify bundle patients easily in the electronic medical record. I would communicate the program in all venues that you can, whether it be your physician's communication, leadership communication, any of your MC4Us, which is our communication for the whole system. And then I would think about hiring in your navigators. Navigators are key to the success of the program. The last thing, that I will add today is identify who you're using for post-acute today. Build those relationships, understand who they are, how often you're using them. Is there one that has a particular benefit? Do they have PT, OT readily available so that they can get your hip fractures up day of admission? So those would be the things that I would do, I think, today. And then in 6 months, I think it's really important to do a SWOT analysis, understand what's working, what's not working, what more support do you need, how can you leverage your team's administrative team to help improve any successes or any opportunities that they might be able to help you with. And then be really transparent and honest. I have to say the teams model or the bundle program is complicated. Physicians are really confused around how that target price is, how they come up with that target price. And you have to do a lot of education around how this works. So that would be my advice for today and for 6 months.
Thank you so much for breaking that down. Moving on to the next question, someone is asking, I'm hearing rumors of AHA and state hospital associations working on advocacy with CMS to remove this mandate. What is your confidence level that this mandate for the team model will stay? And feel free, any presenter, to jump in and comment on this.
Yeah, I would say my level of confidence is 95%. I'm sure, AHA and state hospital associations have been going after this and fighting this. But, the Innovation Center can do these types of models. They can be mandatory. A lot of people speculated since in the first Trump administration, his health secretary, Tom Price, killed a mandatory cardiac bundle, that they do the same thing. But it turns out that the current CMS administration seems to like mandatory bundles, especially when they guarantee savings to the program. So I have very high confidence because this was, they made changes to the model in the proposed inpatient rule, but this is going to roll out on schedule.
Thank you so much. Now, looking on to the next question is specific to looking at different fee-for-service versus value-based care providers. So they're asking for lower extremity joint replacements. Does that mean it benefits the post-acute provider since it's fee-for-service and team payments are done at a look-back period?
Rob, I think you might be on mute.
I think there's risk and opportunity for post-acute care providers. I think typically the philosophy of the hospitals that participate in this is, how do you save money? One of the best ways is to skip the SNF. So, SNFs market pretty hard to hospitals. Sometimes it's just the easier thing to do to say, okay, go ahead, we'll discharge the patient to a SNF. But, if a patient can safely go home, before it didn't matter to a hospital, but now they're on the hook for $15,000, $20,000 per admission. So hospitals are going to be much more diligent about evaluating whether patients can go home. They're not just going to automatically push them to the SNF. And then, as they develop these preferred networks, they're going to be watching them very closely to see how their performance on quality and on length of stay is changing. So I think it's a harder environment for SNFs. I think the very best SNFs can be in all the preferred arrangements in their market and do pretty well. But I think for SNFs overall, this model in particular is probably not great for them.
The one thing I think I would add is just the SNF waiver that's part of the team's model. For, there are some hip fracture patients that are absolutely going to need a SNF level of care. And having the SNF waiver which for folks that aren't aware, the Medicare rule is normally you have to have 3 midnights. In this model, as long as the patient is admitted, they can go directly to that post level of care, which is really important for our hospitals to get those emergency department patients upstairs. So the patients that need to, and there are hip fractures, our little elderly patients may absolutely need SNF level of care. So using that waiver and partnering with those SNFs is really important. But like Rob said, we try really, really hard to get our patients home or home with services. That's where they can heal the best. That's where they'll get up and walk to their own bathroom. That's where they'll eat the best because their family's there. So we work really hard to get these patients home.
Thank you for adding that in there, Jana. Moving on to the next question is more specific to regional target pricing, and it's asking, has regional target pricing been set yet?
They've calculated the preliminary target prices. They may actually have calculated the final target prices. I know some people were curious about when they were going to get data from CMS, and I know some hospitals have reached out to me and they have received their data, although not all hospitals have. And it may be that you had to do something in your application to get it very early, but there will still be an opportunity to get it. I think, you know, it's developed by the consultants that build the model, so I don't find the data that they share very intuitive, but they do include the regional target prices, and they actually project them out to 2026. They include the prospective trend rates that are used to project them out from the base year to the performance period as well. So those should be floating around and should be pretty well established by this point.
That's super helpful. Thank you, Rob. Now, the next question is going back to what Jana was mentioning previously about SNFs. So it's asking, talking about sending patients to SNFs and that they need to be 3 stars or better. What would be the consequence if there is no bed availability at the 3-star or better SNF and had to send the patients to a 1 or 2 star?
Yeah, and we have to do that every so often. And it's a little bit more work and a little bit harder to get their engagement. So in our preferred network, we try to get out there. We have a pretty robust preferred network, and we try to get out there at least quarterly to talk about the program, what the clinical pathways are, how they can get a hold of us. We give our patients a bracelet that is blue so that they know they're from UMass, and it actually has the navigator's number, who really can get a one-call resolution to say, this is my patient, this is how they were when they left. So if they have any questions, they can reach out to the navigator. So we have really tight connections, my navigators do, with those post-acute, and not often, but sometimes they have to go to a non-preferred. And then it's the struggle. They don't know what the bundle program is. They don't know who we are or what we're doing or why we're calling. So it just takes a little bit more work, and it's just much easier to go to our preferred. But we always, and sometimes it's patient's choice. You know, it's informed choice for these patients, and sometimes the family just lives out there and that's where they need to go. So my navigators will call them, they'll try to tell them about the program, who we are. So, but like I said, just a little bit more challenging when they're out of our preferred network. And then the preferred network, you know, having those 3 stars or 4 stars means they have great staffing. The SNF world in Massachusetts anyway has been really challenged since COVID. And with the amount of turnover, it's been really hard to keep them educated to know who we are, what we do. So that's what I would say about that.
Thank you for your transparency with that, Jana. Our next question in audience number is asking, since post-acute providers are included in TEAM, do they bill as usual and receive a reduced payment?
Bill as usual. They're paid fee-for-service by Medicare. And so the way TEAM works is it's not a prospective bundled payment. It's a prospective bundled payment target. And so CMS pays all of the providers, including the physicians, the surgeons, the post-acute care facilities, based on their regular fee schedules. And then at the end of the year, they go back, they say, what were the targets? What was the actual spending compared to the targets? And they determine whether the hospital has to have, receives a bonus or is required to make a repayment. So, yeah, so the payment rates are exactly the same. There's no discounting on payment rates. Yeah, that's correct.
Yeah, I think the impact for skilled nursing facilities in this type of model is more, are you performing high enough that you're in that preferred network and maybe getting more referrals? And then in my experience, like there are some organizations through like a clinically integrated network environment that are maybe exploring, funds flow models that include skilled nursing facilities, but those models tend to be really hard to kind of work out in terms of the distribution and benefits. So it's really less of a kind of financial impact for skilled nursing facilities in this model.
It's something the skilled nursing facilities they're very interested in sharing in the savings, but it's not always the people who are responsible for the bundle aren't always interested in sharing savings with the post-acute care facilities. I think they're basically saying, you do a good job, we'll give you referrals. But not additional payments. That's the majority. There are some organizations that have entered into gain sharing with skilled nursing facilities, but I'd say it's a minority, probably a small minority of groups.
Yeah.
Thank you all for chiming in on that. Moving to a question asking for a little bit more clarification, an audience member is asking, I thought patients were to get a choice of various post-acute providers. How will this be impacted under teams when patients need to be directed to certain providers or settings?
Can you repeat that question? I'm sorry, I'm not sure I got it.
Yeah, of course. They're asking, they came in with the assumption that patients were to get a choice of various post-acute providers. And under the team's implementation, how will this be impacted when patients need to be directed to certain providers or settings, opposed to getting a choice of various?
Yeah. So it's a good question because it's really important that you partner with your case managers. So case management in most hospitals are the ones that direct post-acute and really help to organize it. So part of our multidisciplinary rounds is talking about it. Patients will always have their choice, right? It's a Joint Commission requirement that patients could go anywhere they want for post-acute. So what we do is we just try to show them our preferred locations, tell them that we work really closely with them. We have great outcomes. We have, our providers know them. And so that we just do an informed decision. So I feel like if people have an informed decision, almost always they're going to say, oh, my surgeon wants me to go here because they have great outcomes. My navigator wants me to go there. The case manager wants me to go there. 80% of the time, families will go there based on the recommendations. 20% of the time, families are going to go exactly where they want to go. And that's up to them. And that we can't change those decisions for them. We do the best we can with informed information, and then patients have the choice to go wherever they want to go as long as that facility accepts them. So it's not like we drive them and say you can only go to these places. We case management offers choices, shows them our preferred, talks about our relationships, and then it's up to the patient and for their decision.
Absolutely. I love the way you explain that it's an informed decision and recommendation, but not a necessary choice. Our next question is looking more to specifics of a specific ratio. So do you have a ratio of navigators to patients in the model that you use for staffing?
At UMass, I have one navigator for each service line. So, and right now I think I'm in 7 service lines. And I run the bundle program and others that aren't part of the bundle program. For instance, I run a COPD bundle, not in the bundle program, but I have a navigator that runs that. But for all the others, I have one navigator for each service line. So lower extremity and hip fractures has one navigator, spine has another navigator, major bowel has one. So one navigator to each episode. Now, depending on your volume, you can absolutely look at that. I don't have a ratio, but I can get it for you and send it to somebody. We have, we're in neurology right now, and being a stroke navigator is very different than being an ortho navigator, right? Stroke patients are a lot sicker, more acute, need a lot more care. And the navigator really, for me, is we have a standard rule of what they do, but it's really based on the patient. Some patients need a call every single day to avoid that ED visit or complications. Other patients are great. So it's really around nursing, clinical judgment around taking care of those patients. So I will get you some ratios and send them to this team so we can get them to you.
Thank you so much, Jana. And next question is kind of diving back into the conversation we talked about getting the data specifically for the team's implementation. So to clarify, an audience member is asking, they thought that the hospitals were not getting their team's data until Q4 2025. Do some hospitals have their data today? And if so, how did they get it?
I don't have that answer.
Yeah,
we weren't expecting our
be.
data to the fall, but I think we just got ours yesterday. So we weren't expecting it to the fall. Just got it, I think, yesterday.
Yeah, there's several different tranches of data. So the data that were sent to the hospitals, and I'm a little confused about it too, because there's one multi-hospital system I work with. Some of their hospitals got their data, other ones did not. The data that is summarized doesn't include the entire base period. So it's data from the beginning of 2022 through the middle of 2024. But the target prices are going to be based on the entire 2022 through 2024. So they will probably issue an update of that when they have more complete information. The hospitals that I've talked to have also gotten claims data from that period. And we'll probably get a refresh that has claims data through 2024, although I'm not sure what the timing on that will be. And then, finally, once the model starts, the question about getting it after Q4, once the model starts in the second month, which will be February 2026, CMS will begin to provide monthly stream of data, and so every month you'll get the most current data. Now, when you get the monthly data, it doesn't have very much claims run out, so it's incomplete. So the next month you'll get the incomplete monthly data, but they'll refresh your last month's data and the month before. So eventually the claims data will all become mature, but when you're in the program, you'll be getting an ongoing monthly feed of data.
I just wanted to make one comment. Oh, sorry.
Yes,
I just wanted to add one thing. The target price is so important in the Teams model. Your target price really talks about how sick your patients are. So the more patients you have with comorbidities and complications or major comorbidities and complications, the importance of that documentation is critical. The CMS knows if you have more patients with comorbidities and complications or major comorbidities and complications, it's going to cost more to take care of those patients. So we do a lot of work with our coding team and education to our providers around the importance of documentation. I just wanted to add that because it's been critically important to drive that target price.
Absolutely. Thank you so much for adding that in, Jana. That is all the time we have for today. So I want to give a big thank you to Sarah, Jana, Rob for such an excellent presentation and discussion, as well as GetWell for sponsoring today's webinar. And thank you to all of our wonderful audience members for joining us and inserting such thoughtful questions. To answer some of the questions that we did see a lot, GetWell will be in touch with follow-up material from this session after this concludes. So thank you so much again for joining us, and we hope everyone has a wonderful rest of their day.
Thank you.